Today, we are going to talk about a topic that often causes significant concern among clinicians and parents alike, and that is the appearance of non-blanching petechial rashes in children. This presentation will walk you through the clinical relevance, differential diagnosis, red flag signs, diagnostic approach, and management strategies for children who present with such rashes. The aim is to equip you with a practical, evidence-based framework to confidently assess and manage these cases. So let's start by understanding what we mean by a non-blanching rash. A non-blanching rash is one that does not fade or disappear when pressure is applied. This can be tested using the classic glass test. Petechiae are pinpoint red or purple spots, typically less than 2 millimeters in diameter. When they become larger and more confluent, we refer to them as purpura or ecchymosis. These lesions reflect capillary bleeding beneath the skin. Now, in pediatrics, the presence of a non-blanching rash is especially significant because it may indicate a serious underlying condition. The first and most urgent consideration in any febrile child with a non-blanching rash is meningococcal septicemia. Now, this life-threatening condition can evolve rapidly and demands immediate intervention. But it's also important to remember that not all petechial rashes are dangerous. Children commonly develop petechiae during viral illnesses or from mechanical causes such as forceful coughing or forceful vomiting. So how do we tell which ones are benign and which one require urgent care? So let's look at the red flags. These are the clinical features that should raise suspicion of serious bacterial infection. And they include a temperature above 38 degrees Celsius, lethargy or irritability, delayed capillary refill or hypotension, cold extremities or mottled skin, and a rapidly spreading purpuric rash. It might include signs of meningeal irritation such as neck stiffness or photophobia. It might include altered consciousness or sometimes seizures. If any of these features are present, we must assume meningococcal sepsis until proven otherwise. Time is critical and treatment should not be delayed for investigations. Now let's consider the possible cause of petechial or purpuric rashes and categorize them to aid recall. First, the life-threatening causes. These include meningococcemia, severe sepsis with disseminated intravascular coagulation, also called DIC. It can include acute leukemia and immune-based thrombocytopenia purpura, also known as ITP. Then we have benign infectious causes like enteroviral or adenoviral infections, streptococcal infections, and Epstein-Barr virus infection. And finally, we must consider non-infectious or mechanical causes. These include trauma, coughing or vomiting induced petechiae, vasculitic conditions such as HSP, and even tight clothing or tourniquet effects. So what should you do when you see a child with a petechial rash? The answer depends on the child's general condition. Start with an ABCDE assessment. So if the child appears ill, give high flow oxygen and establish IV access. Draw urgent bloods including full blood count, CRP, coag profile, blood culture, and a blood gas. Administer IV ceftriaxone or cefotaxime as soon as possible. And if there's any suggestion of shock, give a fluid bolus of 20 ml per kilogram of normal saline. And let's say if meningitis is suspected, a lumbar puncture may be needed, but only after ruling out raised intracranial pressure or other contraindications. In contrast, if the child is well appearing, has stable vitals, and no concerning features, a more conservative approach may be reasonable. You may consider observing the child or doing limited investigations depending on your local protocols. Let's now look at two important differentials in more detail: immune thrombocytopenia purpura, ITP, and HSP. In ITP, the child usually appears well but has widespread petechiae or bruising. The platelet count will be low while other blood parameters remain normal. In HSP, which is an IgA-mediated small vessel vasculitis, the classic rash is palpable purpura involving the lower limbs and buttocks. It is often accompanied by abdominal pain, joint swelling, or hematuria. There is no need for antibiotics in HSP, but renal function must be monitored closely both at presentation and also during follow-up. It's also essential not to overlook leukemia as a differential. Children with leukemia may present with petechiae, but they usually have other systemic features such as pallor, fatigue, bone pain, hepatosplenomegaly, or lymphadenopathy. A blood film and bone marrow evaluation are needed if leukemia is suspected. So, to summarize, the presence of a non-blanching rash in a child is a red flag that demands immediate clinical assessment. The majority of cases are benign, but we must never miss the small subset that reflects life-threatening disease. So use a structured approach, assess red flags, perform targeted investigations, and escalate treatment if any danger signs are present. So thank you for joining this lecture on non-blanching petechial rashes in children. I hope this session has given you a solid clinical framework to approach this important presentation with clarity and confidence. So stay safe, keep learning, and see you in the next session. Bye-bye.